So very good evening, everybody. I am Dr. Shweta Gupta. I am a pediatric hematologist at Indiana Hemophilia and Thrombosis Center. And I would like to thank National Hemophilia Foundation to having given me this wonderful opportunity to talk about current treatments for rare bleeding disorders. In today's talk, I'm going to focus on rare factor deficiencies and then move on to talk about platelet function disorders. I have no financial disclosures. And for the purposes of this talk, I will be referring to fibrinogen as factor 1 and prothrombin as factor 2. So the focus of today's talk is going to be all about rare bleeding disorders. And I'm going to break the talk into 3 sections. First, I will focus on the diagnosis. And then I will talk about what is available in terms of treatment today, and then what the future hold in order to improve care for these patients. We all celebrated Rare Disease Day on February 28th, and on its heels, now we are celebrating March as the Bleeding Disorders Awareness Month. So a very appropriate time to talk about rare bleeding disorders, because always the spotlight is on hemophilia and von Willebrand disease. The World Federation of Hemophilia conducts an annual global survey. The one from 2019 was completed by 115 countries. And as you can see from this snippet, people with hemophilia are 4 times as compared to people with the rare bleeding disorders. And people with von Willebrand disease are twice as many as the people with rare bleeding disorders. And that is why the emphasis of the bleeding disorder community has been mainly on hemophilia and von Willebrand disease. But now times are changing. As you can see from this graph from WFH, again from 2019, the number of patients diagnosed with rare bleeding disorders has gradually increased in the last 15 years. The WFH started reporting about rare bleeding disorders since 2004. And as you can see again from this graph, the brown portion, which actually refers to the bleeding disorders unknown, has gradually diminished over the years and has been replaced either by one of the rare factor deficiencies or the platelet function disorders. So definitely a lot of improvement has been taking place in the terms of diagnostics for rare bleeding disorders as well as the reporting. Looking at this table, you can see the most prevalent of rare bleeding disorders is factor 7 and contributes to 38% of all the bleeding disorders. The rarest are the factor 13 and factor 2, and they contribute to a very small fraction of the rare bleeding disorders all over the world. So a little bit about what is the status of reporting in the United States for rare bleeding disorders. Well, it is actually not the best. And the reason for this is that we do not have a systematic data collection and a national database to report rare bleeding disorders. However, in the past few years, an effort has been made to improve this. The Center for Disease Control and Prevention, the American Thrombosis and Hemostasis Network, and the US Hemophilia Treatment Center Network have collaborated and partnered with each other in order to leverage the Community Counts Initiative. This in turn has 3 components: the HTC population profile, that is Hemophilia Treatment Center population profile, the registry for bleeding disorders surveillance, and the mortality reporting dataset. Now, the HTC population profile dataset has very basic demographic information about the patient. However, the registry has a lot of information which is helpful for providers and researchers to understand the rare bleeding disorders. This information is like what kind of treatment you're receiving, what is the product, how are you being treated for surgeries, are you on prophylaxis, what are your joints doing, do you have an inhibitor? So definitely what we need to do as providers is to include all the patients with rare bleeding disorders into the registry so that we can close the knowledge gap of rare bleeding disorders. Unfortunately, the proportion of patients with rare bleeding disorders in the HTC population profile being enrolled in the registry is very less, only at 10.8%. So lots of work to do here. Now, this complicated table, it basically is highlighting one point, and that is the observed number of cases in the United States for the rare bleeding disorders like factor 1, factor 2, factor 10, factor 5, and 8 are actually much less than the expected number of cases. And hence, again, the emphasis on reporting and diagnosing rare bleeding disorders is very important. Let's talk a little bit about the diagnosis of rare factor deficiencies. Now, this is extremely challenging. The reason rare factor deficiencies are challenging to diagnose is that because of the fact that they're not very prevalent, clinicians lack the knowledge base to diagnose these conditions. Moreover, they have a heterogeneous group of disorders which could present with symptoms like nosebleeds, bleeding with cuts and wounds, heavy menstrual bleeding, and this can be seen in other conditions like platelet function disorders and the common von Willebrand disease. So patients with rare factor deficiencies can be misdiagnosed, or their diagnosis can be completely missed if the clinician is not astute enough to run some basic coagulation tests and factor levels. It is also important to remember that in the diagnosis of bleeding disorders, family history plays an important role. However, in rare factor deficiencies, there is usually an autosomal recessive pattern of inheritance, which means that the child inherits one defective gene from both the parents, and hence the parents are not affected. The family history could be absent in a majority of cases. However, if there is a severe deficiency of a rare factor, it can be easily diagnosed by doing basic coagulation tests, which are available even in the smallest of labs all over the world. It is important for clinicians, however, to have an high index of suspicion in order to do this testing. It is also important to see that if the clinician knows what are the characteristic bleeding symptoms in the absence of a particular factor, that could give him or her a clue to the diagnosis. For instance, if you have factor 1 deficiency, which is fibrinogen disorder, you would have no fibrinogen detectable in the assays, and you could present very early on in life with umbilical cord bleeding or a history of several miscarriages. Similarly, in factor 13 deficiency, you could present very early with bleeding in the head or intracranial hemorrhage and umbilical cord bleeding. If you have recurrent joint bleeds, you could have factor 2 or factor 10 deficiency. If there is bleeding with circumcision, it could be because of combined factor 5 and 8 deficiency. So basically, clinicians need to be more aware of rare bleeding disorders and should know the appropriate tests which need to be run. For factor 13 deficiency, the normal coagulation assays are not going to capture it. A specific factor 13 assay will have to be run to diagnose it. Now, for the longest time, patients were classified into mild and moderate deficiency of the rare factors based on hemophilia guidelines. But now, due to the work by Dr. Pevandi, we know that individuals with rare factor deficiencies have different cutoffs for mild and moderate deficiency. We also know that there are certain asymptomatic levels which we need to target as providers so that patients do not bleed. Also important to remember is that individuals who have severe deficiency of factor 7 and factor 11 might not have severe bleeding symptoms. So if you are a factor 11 individual and you have a factor 11 of less than 1%, you might not have severe bleeding symptoms. And that is because levels do not correlate with bleeding symptoms. So moving over to platelets, and our platelets look very simple under the microscope. However, as this particular figure shows here, they are extremely complicated structures, and they have complex biochemical and signal transduction pathways. A defect in any of these can result in bleeding symptoms. As you can see in this particular table here on the right side, if there is a defect in the intercellular parts of the platelet, you could have alpha granule issues, which is called gray platelet, Quebec platelet, or storage pool deficiency. There could be issues with dense granules, resulting in Shidak-Higashi, Hemansky-Pudilak. Cytoskeleton defects results in May-Hegland disorders and giant platelet issues. Enzyme problems could be present, or you could have severe platelet disorders reflected through glycoprotein receptor issues like Bernard-Soulier and the Glanzmann thromboasthenia. When you have platelet dysfunction, you have to realize you could have bleeding symptoms which are quite similar to more common von Willebrand disease, as well as the rare factor deficiency. As providers, we have to be cognizant, make this differentiation by not only taking a thorough history, but also doing a physical examination, because it can give clues to platelet disorders. There are certain platelet disorders which are associated with physical abnormalities like hair discoloration, skin issues, bony abnormalities, heart defect. And this is because platelet disorders are associated with syndromic presentations. And most importantly, when providers order labs, they have to be done at a specialized, reliable lab, because a lot of individuals get diagnosed with platelet function disorders when they don't have one if the lab was not the right one. Tests for lab diagnosis are several. The most important is platelet electron microscopy, as well as light transmission aggregometry, where we look at the platelet function with different agonists, looking at aggregation and release. And then for the severe platelet dysfunction, we measure surface glycoprotein levels with flow cytometry. Always, we need to consider medications while we are evaluating patients for platelet dysfunction, because certain medications like non-steroidal anti-inflammatory agents, anticonvulsants, as well as antidepressants can affect platelet function. Some of the severe bleeding disorders for platelet dysfunction are Glanzmann and Bernard-Soulier syndrome. Glanzmann is due to a fibrinogen receptor defect in platelets, presents very early in life. You could have very severe bleeding symptoms, joint bleeds, and with Bernard-Soulier, you have a decrease in platelet count, as well as an increase in platelet size, and bleeding could be moderate to severe. Both of these conditions are inherited, again, autosomal recessively, so there might not be a family history. So moving on to the treatment. Now, let's first talk about the rare factor deficiencies, and I wanted to highlight on some key points. While treating rare factor deficiencies, we as providers need to keep in mind to evaluate the clinical response while giving factor or product to a patient. And this is specifically important for developing countries where it might not be easy to run the factors very frequently. Even in established centers in the United States, doing factor levels very frequently could be a cost issue and might not be easily available. Thereby, evaluating a patient clinically is very important while giving factor concentrate. Cryoprecipitate is a product which has factor 1, which is fibrinogen, factor 13, von Willebrand factor, factor 8, 9. It can be used thereby for fibrinogen as well as factor 13 deficiency. Viral inactivated plasma has all the factors and can be used for all rare factor deficiencies. However, a lot of plasma has to be given in order to compensate for a factor deficiency, and that could result in volume overload and risk of allergic reactions. Recombinant products, which do not have any animal or human protein and are very safe, are however not very common in the rare factor deficiency world. We have them only for factor 7 and factor 13. All other factor products are plasma derived. Specific factor replacement is not available for factor 2 or prothrombin and factor 5 all over the world, and for factor 11 in the US. Individuals with factor 2, factor 7, and factor 10 deficiency can be treated with prothrombin complex concentrate. However, as providers, again, whenever we are treating patients with any factor deficiency, we have to be very vigilant about the risk of forming blood clots, specifically with factor 11 concentrate, recombinant factor 7 replacement, PCC or prothrombin complex concentrate, and fibrinogen disorders. While giving product, and specifically if giving too much product too frequently, we have to remember the risk of inhibitor and antibody development, which could result in delayed response to the factor product. And always remember the first principle of medicine as providers: first, do no harm. So this is a table which gives you information about the different products which are available for each of the rare factors. It also tells you in the third column here, what are the levels that we are trying to aim for as providers to stop a major or a minor bleeding, as well as to take care of you during surgeries. These are the levels that we would target. And it also gives information about the half-life of each of these products. And that is important, as well as the factor. And that is important for us as providers because it gives us the frequency at which we have to dose you. It could be either very frequent for products like factor 7, where it is about 4 to 6 hours, or it could be infrequent, about 9 to 12 days for products with a longer half-life like factor 13. So as I had mentioned, FFP can be used for all of the factor deficiencies. PCC or prothrombin complex concentrate can be used for 2, 10, and 7. Cryoprecipitate for factor 1 and 13. And then for the other factor deficiencies, we do have plasma-derived products which have a different dosing as compared to recombinant products as available for factor 7 and factor 13. Now, I do want to emphasize that there are agents that we can use along with factor concentrates of plasma, and these are antifibrinolytic agents. Antifibrinolytic agents are very important as adjunctive treatment. They include tranexamic acid and aminocaproic acid. Tranexamic acid is one which is available both as intravenous and oral. It is 10 times more efficacious as aminocaproic acid and can be used also for patients where factor product is not available if they're having a minor bleeding episode or a minor procedure like a dental extraction and does not have a severe deficiency of the factor. Now, desmopressin acetate has been used for factor 5 and 8 as well as for factor 11. It is a universal hemostatic agent and works by increasing the platelet stickiness and its adhesion to vessel wall, as well as by different other mechanisms, and thereby can be used where product is not available. Recombinant factor 7A has been used for factor 5 deficiency as well as for factor 11 deficiency. I would also want to highlight that in certain conditions, where there is a minor nosebleed or a minor procedure, local hemostatic measures like nasal packing, fibrin glue, fibrin sealants can be used instead of using antifibrinolytic agents. This particular slide shows you the prophylaxis dosage for different rare factor deficiencies. And as you can see, in patients with 7, we might have to use the prophylaxis 3 to 4 times a week, whereas in factor 13 deficiency, you can get by using the product once every month, once every 3 weeks. Now, individuals who have severe deficiency of the rare factors and have a severe bleeding phenotype, which means they've had recurrent intracranial hemorrhages or they've had recurrent epistaxis, would be candidates for long-term prophylaxis. However, certain individuals would require short-term prophylaxis, for instance, around the time of heavy menstrual cycles, at the time of pregnancy, at the time of postpartum care, or sometimes they might require short-term prophylaxis if they have like a GI bleed. Platelet disorders, the general treatment guidelines include the use of, again, desmopressin acetate, which would cover a majority of the platelet dysfunction. However, in severe bleeding disorders where desmopressin will not work, like Klansman, recombinant factor 7A needs to be used. Sometimes platelet transfusions might be required. However, one has to be very careful about the risk of transfusion-transmitted disorders, allergic reactions, as well as alloimmunization, which is the development of antibodies when you give platelets too frequently. Again, antifibrinolytic agents as adjunctive treatment and local hemostatic measures like in rare factor deficiencies play a very important role and are cheaply available. I would like to spend just a minute or two on the rarest of the rare bleeding disorders, because these are not being captured even with the WFH and the ENRBD survey very efficiently. And we know we are seeing the tip of the iceberg, but there are patients with vitamin K dependent coagulation factor deficiencies, and less than 50 families have been reported. It is autosomal recessive. And again, the treatment is vitamin K. Alpha-2 antiplasmin deficiency is autosomal recessive, presents with, again, epistaxis, bleeding in the spinal cord, umbilical cord bleeding, and you have to do a specific assay in order to find out if the patient has reduced antiplasmin activity. Plasminogen activator inhibitor deficiency is very rare. Here in Indiana, up north, we have a huge pedigree of PI1 deficient individuals who have severe bleeding phenotype, delayed wound healing, heavy menstrual bleeding, as well as postpartum bleeding. Again, specific genetic testing as well as activity and antigen ratios are important to diagnose these conditions. Treatment is use of antifibrinolytic agents and fresh frozen plasma if there is severe bleeding. Again, only a few case reports being published for factor V shot, which includes East Texas bleeding disorder and factor V Amsterdam. Patients are presenting with mucocutaneous bleeding, delayed wound healing. It was thought that this is only limited to East Texas or Amsterdam, but now we did find a family here in Indiana with the East Texas bleeding disorder. It is autosomal dominant, and again, treatment of choice is recombinant factor 7A, antifibrinolytic agent, and APCC. Very recently, on whole genome sequencing was found the deficiency of factor, tissue factor. This is only due to sequencing of factor 3 because the normal coagulation assays cannot detect this deficiency. It is autosomal dominant. And again, the bleeding symptoms are similar to what you would see with any other blood disorder. So very quickly, I wanted to talk about a specific topic which is near and dear to my heart, which is women with rare bleeding disorders. And the reason is that women do face the brunt of excessive bleeding due to heavy menstrual cycles as well as reproductive tract bleeding. Also, we need to remember that women could have hemorrhagic ovarian cysts as well as miscarriages. It is very important thereby for providers to focus on the care of young women and girls with bleeding disorders. For heavy menstrual bleeding, the go-to therapy is safe medications involving estrogen and progesterone combination pills or only progesterone therapy. For heavy menstrual bleeding, you could also use antifibrinolytic agents. However, some women have such severe bleeding that they require short-term prophylaxis with factor replacement around the time of their menstrual cycles. Again, due to the efforts of Dr. Pavandi and Dr. Menegatti, we now have published guidelines as to how to take care of women during pregnancy, labor, and delivery if they have a rare factor deficiency. Afibrinogenemia is a condition which could result in miscarriages, and so is factor 13. It is very important to keep levels of fibrinogen more than 1 gram per liter in order to maintain the pregnancy. For factor 13, these levels have to be around 10 to 20% until the 22nd week of gestation, and then at about more than 30% at the onset of labor. It is also very important to remember that in the pregnancy, as well as the postpartum period, there is a very fine balance between bleeding and clotting. And this is because pregnancy and the postpartum state are states of high estrogen, which can result in blood clots. Providers need to be aware of this risk and be very vigilant. Of course, the use of antifibrinolytic agents is very important during the antenatal as well as postpartum period to prevent excessive bleeding. This particular slide tells us how to optimize the care of a woman with bleeding disorder throughout their lifespan. As soon as you know that the young girl has a bleeding disorder, one should do the levels for the particular factor. A genetic counselor should meet the family. They should explain the pattern of inheritance, be it autosomal recessive or autosomal dominant. Just prior to starting menstrual cycles, you should meet your provider in order to know what could be expected from a normal menstrual cycle, what is heavy menstrual cycle, what kind of treatments are available. Antenatal counseling is important, specifically if it is an autosomal recessive disorder, or if you live in a region where consanguinity is common, because in those scenarios, you would want your partner to also get tested. Prenatal diagnosis is important in order to know whether the child is affected or not, but this can be done only if the mutation for the rare factor deficiency is known at a specialized center, because there's a risk of bleeding. And as I said, labor, delivery, and postpartum care has to be emphasized. All throughout the lifespan, make sure that you're connected to experts through a hemophilia treatment center. Make sure you receive education. Make sure you ask questions to your provider. If you are going to have a surgery, let the provider know much ahead of time so that they can form a hemostatic plan by talking to your surgeon and sending detailed letters. If iron deficiency is present, make sure it is treated early and aggressively, because iron deficiency could result in mood swings, depression, poor quality of life, and increases your risk factors for developing blood clots. It is also important for women to remember that a psychologist is always available at a hemophilia treatment center. And if not, then talk to your provider. Women do face a lot of emotional burden because they are also carriers and transmit diseases of the rare kinds to the ongoing generations. Comprehensive care model, which involves the multidisciplinary team with genetic counselors, psychologists, nursing, social workers, and different kinds of physicians, including pediatric, adult physicians, surgeons, and obstetricians and gynecologists, will ensure that proper care is provided to rare bleeding disorder patients. It is important to increase the awareness among women about the bleeding disorders. For the longest time, it was thought that bleeding disorders are only in men because of the importance given to hemophilia. We know rare bleeding disorders affect females, and they do have severe bleeding symptoms. Victory for Women is a platform by National Hemophilia Foundation, which gives them a chance to talk about their bleeding disorders, share their stories, and gives education. Similarly is the Foundation for Women and Girls with Blood Disorders, which educates providers, hematologists, and obstetricians about all kinds of bleeding disorders. So what is there in the future? Well, we do have some products, hopefully, in the pipeline. One is the recombinant factor 7, which is fused to albumin. That would be a longer half-life, and thereby we would not have to give recombinant factor 7 so frequently. There is a plasma-derived factor 5 concentrate, which has been tested in the lab and has found promise. So hopefully this would be in clinical trials soon. There is non-factor therapies, which is being tried and tested in the world of hemophilia. This is the small interfering RNA technology, which would decrease the antithrombin, which is a natural anticoagulant in your blood, and increase thrombin generation, which helps to form a stable clot. Similarly, we have the anti-TFPI monoclonal antibody, which would do the same, make a stable clot by bypassing the normal coagulation pathway. Gene therapy, well, we have ways to go for this for the rare factor deficiencies, but we are making strides in the hemophilia world. So hopefully, in maybe the next decade, we will be talking about gene therapy for the rare factor deficiencies. So what are the challenges we face in treating these patients who have rare factor deficiencies? Well, as a provider, I can tell you that there is absence of evidence-based guidelines. We don't know the prevalence of so many of the rare bleeding disorders. There is lack of expertise in the management of the rare factor deficiencies. There is a variation in the clinical response of each individual person. There is lack of information about the genetic mutation which is causing the defect, and we don't know what is the correlation between the genetic mutation and the bleeding symptom. There are limited treatment options, specifically in the developing nations, and we rely heavily on products which might not be very safe, like fresh frozen plasma and cryoprecipitate. We know some products, like fresh frozen plasma and frequent platelet transfusions, may be associated with thrombosis or allergic reactions, or even alloimmunization. In an ideal world, it would be optimal if every individual with rare factor deficiency and his or her family can snugly fit in the circle. However, we know this is not the case. Before diagnosis, patients have to shop from one doctor to the other, and even then, they might not have the proper diagnosis, and the diagnosis could be delayed. There are barriers to access to experts and availability of hemophilia treatment centers, which are established with experts in developing countries. And even if you're connected to an HTC with experts, it is important that there is availability of the right product at the right time, specifically in emergent situations. It is important that there are opportunities given to family members to know their mutation and to get screened for the rare bleeding disorder. And finally, it is very important for the data that comes from registries and researchers that it is published in a timely manner so that it is disseminated to the consumers as well as to the providers to close the knowledge gap. Finally, what are the take-home points? Well, as a patient, be your own advocate for your bleeding disorder. Get connected to hemophilia treatment centers and national experts. Know your bleeding disorder well and carry a card with emergency numbers. Wear your medical alert bracelet always. Carry a travel letter which lays down the plan for your treatment. If you are a young girl or a woman, find a woman's or a girl's bleeding disorder clinic. Seek counseling prior to menstrual cycle, prior to conception. Know your risk during pregnancy for bleeding, the risk of bleeding during labor and delivery and postpartum. See high-risk obstetricians, maternal fetal medicine, along with your hematologist. Cord blood testing is very important for patients with severe bleeding disorders because they're present early in life. Have all your medications handy, make sure they're not expired, and know what products to use when. Local hemostatic measures are very helpful. If you have a severe bleeding disorder, know how to infuse. Make your providers aware of minor and major procedures. Know where to receive emergency care. Avoid medications and herbals or supplements that increase bleeding risk. Avoid contact sports. Make sure to be immunized against hepatitis A and hepatitis B because there could be an exposure to plasma-derived products. Finally, get family members tested. Understand the genetics. Understand if your disease is inherited in autosomal dominant or autosomal recessive manners. Participate in research and registries so that providers and consumers can benefit from whatever information they can get. Keep yourself informed by using reliable resources and attending national and international meetings. These are a few websites that are reliable and provide good information to providers as well as to consumers. So in summary, rare bleeding disorders can be mild to severe. Complete family history and a thorough lab diagnosis is very important in order to ascertain what rare factor deficiency you have. Genetic counseling is important for future generations. Treatment products definitely need to be developed. Future research is needed. Be well informed today to ensure a better tomorrow for your children. And that is it. So thank you so much. I'll be happy to take any questions that you might have.
Thank you so much, Dr. Gupta. That was a really fantastic summary of what current treatment options are out there. And we have some wonderful questions coming in. So the first question that I wanted to ask you, you mentioned recombinant factor multiple times. What does that word recombinant actually mean? Does that mean it's derived in the laboratory, or where does that come from?
That is a very good question. In this day and age, we are relying, if possible, more on the recombinant technology. In this particular technology, it is a product which is produced without any exposure to animal or human plasma protein, and thereby it is genetically engineered. So it is safe from the risk of virally transmitted infections and is the way to go. In an ideal world, it should be for all factor deficiencies, but at present, we definitely have it for hemophilia. We have it for recombinant factor 7 is available. We have recombinant factor 13 also available. And hopefully, we will have it for the other products. We do have it for von Willebrand products too, but it is still in clinical trials for pediatric patients at least.
Fantastic. There's another question that's coming in from the audience here along the same lines. You also mentioned desmopressin. What exactly is that?
Very good question. So desmopressin acetate is a medication that we have used for patients with bleeding disorders, for instance, mild hemophilia and von Willebrand factor deficiency. So desmopressin is actually also used for bedwetting, but this medication, when it is used for bleeding disorders, it has a different concentration, a much higher concentration. And what it does is it helps to release von Willebrand factor and factor VIII from the cells where it is produced, that is the cells which line the vessel wall. It also works in different mechanisms, like it helps in increasing platelet stickiness, as well as the attachment of the platelets to the vessel wall. So because of the fact that it works through different mechanisms, it is very helpful in any kind of bleeding disorder where you don't have a factor product. So in certain conditions where we don't know what is the patient's bleeding disorder, despite all the evaluations we have done, we have used desmopressin acetate. It can be given either intravenously, that is in your vein. It can be given under the skin. And in fact, it was also available as a very easy way, just as a nasal spray. However, this is no longer available. It's on recall. So once it is available, it is very easy for patients to keep handy at home and use it. Desmopressin is also used for factor 5 as well as for factor 11 deficiency. When you don't have product available, you can use desmopressin on PD-AVP.
Mm-hmm. There's another question associated with that. So with obviously the nasal spray being on recall right now, what should patients take instead of it?
Yeah, so, you know, we are struggling, but we have other ways of giving desmopressin. We are using the intravenous form, that is, you have to give it in the IV form, or you can also give it under the skin. However, the disadvantage is that it has to be done at a medical facility. We have started training some of our patients who require desmopressin very frequently to give it at home under the skin. It's like a diabetes shot. And for this, you know, in this day and world, because of COVID, we are using videos, we are using virtual Zoom calls in order to train our patients. And if they can come into the clinic, then we teach them how to give the shot at home.
Okay, that's great to know. That's really wonderful information to have. There's another question that's coming in from the audience here, and this is just asking you to clarify one of your points in regards to PCC being given for factor 7. And this person said there that they have heard before that there are varying amounts of factor 7 in it. Could you just clarify that a little bit for them?
Yeah, so that is a good question. For the most part, prothrombin complex concentrate is not being used for factor 7 deficiency. It is only in those parts of the world where you don't have recombinant factor 7 or plasma-derived factor 7 available that you would have to use PCC. And your provider should be able to actually dose you because in an appropriate manner, because the dosing of the PCC is based on the 49 unit. So one has to be very cautious based on what kind of PCC product you have, because there are different companies manufacturing it. So one has to be very cognizant of what dosing is used. But if you have 7 deficiency, the person who asked the question, it would be ideal to use either recombinant factor 7A or plasma-derived factor 7. And I'm hoping that that is available where you live.
Wonderful. Thank you so much. So unfortunately, we are already hitting the end of our wonderful session with you. So again, Dr. Gupta, thank you so much for sharing your insights with our community. I'm sure everybody really enjoyed learning more about the treatment options that are out there. So thank you for this.